All right. Okay, talk 5. Thanks for coming back. We're going to talk to you about a brief introduction to PROMs, patient-reported outcome measures, and how PROMs might or can improve healthcare. Okay, this is the background and context. This is a report from the King's Fund, which is a policy think tank in England. I don't know if you've heard about it, of the King's Fund. But essentially, 2010, they did a lengthy report called Getting the Most Out of PROMs, and they summed it up very well. Despite a century of developments in medical technology and vast improvements, the ability of medical science to prevent, diagnose, treat disease and ill health, attempts to measure the outputs of healthcare in terms of their impact on patients' health have not progressed beyond Florence Nightingale's time. So for only many, many years, the outcome we measured has been death. But while Florence Nightingale collected data on the dead, alive, our routine collection of outcome data has continued to be of similar focus, dead or alive, dead or alive. We haven't really progressed beyond it, this is what we're trying to say. The background. The context of outcomes is, well, we already looked at quality and effectiveness, and essentially what we're really interested in is what is the outcome of the patient. We have some reasons for healthcare. Essentially, we want to live longer. But not only do we want to live longer, we want to increase our number of years, but also increase our quality of life so that we're living longer and better. So I think the two together can help us summarize as two aspects of what we can see as better health outcome. And essentially, we want to know, essentially through the effectiveness of treatment, whether or not we are having better health outcomes, so longer life and better quality of life. But traditionally, our health services have focused on measuring one single outcome, mortality. And that is important. We know that, however, that helps us know whether or not we're surviving, we're living basically. But it's binary, isn't it? And it only gives us a part of a picture. And with medical advances in technology, lots of people are no longer dying. We are surviving, alive. Outcome 1, alive. So, but are we living better? Are we living longer? And how's the health, the quality of life of the survival? And increasingly, this is becoming more and more of an important and more of a focus now, because things are not fatal, comorbidities, but can cause considerable disability or reduce quality of life. Okay, so measuring health. I mentioned traditional ways of measuring. We like to measure mortality, very important. We need to continue to measure it. There's no way saying we don't need to measure mortality. Then also, we are very used to measuring impairment, recording symptoms and signs, recording mobility of the patient, how much pain they have. These are all what we learned from day one of medical school. There's mostly clinician reported loss, abnormality of physiological function, anatomical function. Every clinician is very well trained, and we're used to doing that. And in the health service, routinely, these are recorded in case notes and can be pulled up as a form of routine assessments quite easily. So yeah, these are usually clinically reported by nurses, doctors, the clinical team. Now there is an increasing focus to measure in terms of symptoms, functional status and disability. The WHO calls it now activity restriction. And also health-related quality of life or well-being, what they call activity participations, different terms, but essentially measuring the same things. And also satisfaction with outcomes. The last is patient experience, or some people call it PREMs. They're different from PROMs, okay? But essentially, increasingly, health status, health symptoms, disability, quality of life, health status and well-being is increasingly important to capture, are we living better, that question. And these have to be patient-reported. So either patient-reported outcomes, these the first two, or patient-reported experience should be the last one. So that's why these are necessary to be patient-reported and are essentially subjective measures. Okay, so how do we measure health data? 3 different ways of doing that. Clinician-reported, which I also mentioned, patient-reported, and also objective clinical measures. Okay, so there's often a cause of confusion in the field of measurements between objective and subjective measures. I just want to clarify it here that a lot of clinicians kind of feel that usually objective measures are seen to be more trusted and better than subjective measures, and that is incorrect. We know objective measures such as blood tests, X-rays, and observations from examinations, etc. And we know that that's objectively measured, but it's a statistical probability, varying. But a blood test can say, are you outside the normal range or in the outside when abnormal, inside normal? But there is a probability and a distribution. Okay, clinician and signs from clinical examination are objective with a degree of subjectivity. Okay, so when a doctor assesses how much pain the patient has, they're using their own subjective judgment. For example, the degree of knee movement, pain on abdominal examination. Okay, that's a degree of subjectivity. Then we've got things like quality of life, how the patient feels they can. And that, if we want to know that can only be subjective. Okay, so whether or not, so for example, if you want to look at dietary supplement, whether taking this tablet will increase your red blood cells, you can have an objective measure. All you need to do is give this patient tablet after tablet after tablet, and then take some blood and see if the red blood cells have increased. Then they know it's sufficient. This is if that's what you want to know. But if you want to know how taking this dietary supplement, this tablet, affects this person's symptoms, then you need to ask a subjective assessment. You can't just measure the red blood cells. You have to ask them, are you feeling less tired? How's your fatigue? Questions about the symptoms. And that is from the patient's perspective. So the objectivity and subjectivity doesn't mean one's more accurate or more trusted. They're both used for different things, and that's important to know. There's also a lot nowadays of validated instruments to be able, for us to ask subjective questions, which has good validity for objective states. So for example, an objective measure of how far someone can walk. You can do a neurological examination and watch someone walk a distance and walk back. You can watch someone climb a flight of stairs and come down a flight. So those will be objective measures and then record it. 100 meters, fine. But you can also ask someone, can you walk up a flight of stairs without much pain? Can you walk up and down the flight of stairs? And then they will tell you, and that would be patient reported. And that would be a subjective measure versus an objective measure, but they have very good and accurate validity. It's more difficult to get someone to go to someone's house and watch them walk up and down the stairs. Much easier to ask a subjective through a questionnaire. So that's why short functional status questionnaires are now validated and getting more relevant and much easier to do, and have excellent reliability and validity. So that's why subjective measures are now widely used. Just to give you a background on patient-reported questionnaires. Okay, so a little bit more background. In England, in the last 10-15 years, there's been a steady shift in how we should be measuring the quality of care. Essentially, nicely summed up by Lord Aradazi, which led the sort of a clinical review in the strategic quality of care back in the late 2000s. And so he said, if quality is to be at the heart of everything we do for the NHS, he's talking about, it must be understood from a perspective of patients. Patients pay regard to both clinical outcomes and the experience of the service. So he's saying we have to ask it from the perspective of the patients. And Donald Berwick also wrote, an American this time, that the ultimate measure by which to judge the quality of medical effort is whether it helps the patients as they see it. So increasingly, health services has a more focus to be patient-centered And we always hear people say, patient-centered care, patient-centered service, that's how to make our service more patient-centered. And they can mean lots of things, but essentially it's asking the patient's perspective of how they see it, through their experience of it, but also through their outcomes. And PROMS is talking about how they see their outcomes.